evening. Dr. Jonathan Pinto is a gastroenterologist with an office at 140 East Ridgewood Avenue in Paramus. He completed his medical degree from St. George's University School of Medicine, a residency in internal medicine, as well as a fellowship in gastroenterology from Harlem Hospital Center. Dr. Pinto also completed a master's in public health from Columbia University, Mailman School of Public Health. He is board certified in internal medicine, obesity medicine, as well as in the subspecialty of gastroenterology. And now I'd like to turn it over to Dr. Pinto.
Thank you for the introduction, and good evening to everyone that's joining us. Thank you for joining the presentation. I'm going to be talking about Crohn's disease, and hopefully you learn a little more about the disease and how it's managed. We'll get right into it. I have quite a few slides, so hopefully we can get through it relatively quickly so we have some time for questions afterwards. But in general, what is Crohn's disease? Crohn's disease is one of the inflammatory bowel diseases, which the umbrella covers both ulcerative colitis as well as Crohn's disease. Today, we're going to focus more on Crohn's disease, which is a little different than ulcerative colitis in both its presentation as well as its management. So in terms of symptoms, what kind of symptoms do you have when you have Crohn's? Typically, you'll have abdominal pain. Sometimes this can be sharp or crampy. You have diarrhea. Oftentimes, you have blood in the stool. There are also some what we call extraintestinal manifestations, which just means some symptoms outside of the GI tract, which we'll get into a little later and discuss in detail. So in terms of diagnosis, how are you diagnosed with Crohn's disease? So I'm sure everyone has had stomach pains at some point. Many of you, of course, had some diarrhea at one point or another. Blood in the stool, maybe not so often. However, how do you know? Are these symptoms really Crohn's disease? Could it be something else? The way we investigate this are by doing serology or blood tests. There's some stool tests also give us some clues whether or not there's any inflammation going on in the body. You can do imaging such as CT scans or MRIs. But really, the definitive test is going to be an endoscopy, or you put the camera down the mouth into the stomach and look into your small intestine, as well as a colonoscopy, which we are showing here in the diagram, looks all throughout the colon. And typically, we also look into the end of the small intestine where it joins the colon. So what causes inflammatory bowel disease? So we know there are quite a few factors that influence whether or not one can get inflammatory bowel disease, including Crohn's. The most important is genetic susceptibility. So if someone in your family has Crohn's or inflammatory bowel disease, you are definitely more susceptible or more likely to have Crohn's as well. They've been shown to be a high correlation between identical twins that have Crohn's and as well as family members, whether or not they're first degree or second degree relatives. Other factors, there are definitely a lot of environmental factors, some known, some that are not known. We'll get into those a little later, but smoking in particular is one of the main risk factors for developing Crohn's disease. In terms of your microbial flora, which just means the bacteria that's in your GI tract. Of course, we have bacteria all over our bodies, including inside our GI tract. They're both good bacteria as well as bad bacteria. And that balance of good and bad bacteria is very important for keeping a normal digestive system. So when that balance is a little off, that can influence the development of inflammation, which leads to Crohn's. There's also something called the hygiene hypothesis. Not proven, but they suspect that when you grow up in a very sterile environment and you have lack of infections, that may make your immune system a little more hypersensitive, and that can increase your risk of developing Crohn's as well as other autoimmune disorders. But essentially, all of these factors influence your immune response and your own immune system, which defends your body, starts to attack your GI tract, causing inflammation. So let's talk about the microbiome, which is something of a, I would say, hot topic of maybe the past year or two. Something that was not very well understood. Still, we have a lot to learn about the microbiome, but the balance of bacteria, again, very important for many bodily functions, but especially gut health. So this is a diagram showing the difference in the microbiome or the bacteria in stool samples taken from people in Florence, Italy, as well as Burkina Faso, in West Africa. So you can see there's a stark difference. Just looking at the pie chart here, there are a lot of different bacteria that have maybe some overlap, but different quantities and a lot of significant differences, particularly in what we call the firmicutes here on the darker side. So what changes happen to your bacteria in inflammatory bowel disease? So when you look at this diagram on the right here, with the average Crohn's patient, you can see the largest area there is the dark red, which is the firmicutes. This bacteria is definitely much more associated with people with inflammatory bowel disease, especially with Crohn's. And so definitely a very important aspect. So this diagram here is a little busy, but I just wanted to show an overall view of what happens in your GI tract. So you can see here where the bacteria are. This is on the inside of your intestine or the lumen of your GI tract. So this is where the food will pass by, the stool, etc. On the other side of that, that gut lumen, you have different cells here. They are all involved in different aspects of the immune system. And some of them will sample what's going on in your GI tract. And from that, they determine, is there any infection going on that we need to react to and defend the body? Essentially, in inflammatory bowel disease, because it's an autoimmune disorder, your gut autoimmune system, or your gut immune system starts to turn on itself. So all of these mechanisms of action that activate all of these cells that go to defend your GI tract are potential areas where we can block the reaction to treat Crohn's and inflammatory bowel disease. So again, this is another slide that shows quite a few details, but overall, I just wanted to show that there are a lot of different mechanisms of action, both on the genetic side as well as environmental, that can impair your GI tract, causing this reaction with the chronic inflammation from the immune system. Things I want to really point out: diet, which heavily influences the balance of bacteria or your microbiome. Having an appendectomy also has, we suspect, a big effect on your microbiome or your gut GI tract health. Use of antibiotics and smoking, which is particularly a big one for Crohn's. So in terms of the epidemiology of inflammatory bowel disease, overall, both Crohn's and ulcerative colitis, which are both inflammatory bowel diseases, are increasing worldwide. Mostly seen in the Western world, so North America, Europe, it's the highest prevalence, about 200 per 100,000 in the population. But we also are seeing an increase in incidence in Asia as well. So this diagram here again shows the highest prevalence in North America as well as Europe. Again, a lot of environmental factors here are at play in terms of Western diet. And we can particularly see this when we have patients that have migrated from other countries to North America or Europe. And whereas in their home countries, inflammatory bowel disease is relatively low prevalence. Those same patients have an increased risk for developing inflammatory bowel disease when they migrate to these other countries. So again, getting a little more specific, North America, Crohn's has about between 44 to 200 per 100,000 incidents. Ulcerative colitis, around the same per 100,000. Slightly on the lower side for Crohn's in Europe, depending on which area, as well as ulcerative colitis. But you can see both North America and Europe relatively the same incidence. So when is inflammatory bowel disease, in particular Crohn's, diagnosed? So Crohn's has what we call a bimodal distribution. So you can see the graph here shows two peaks, the highest peak coming between age 20 and 30 years. And we see another peak a little later on in life between 60 and 70 years. So oftentimes we have patients that are in their 70s and they think they're too old to be diagnosed with a new disease like Crohn's at their age, but it's not uncommon. We do see this second spike at that time in life. So in terms of women versus men, in areas of high incidence, so North America, Europe, typically we see women get Crohn's disease a little more often. But in other countries, when they have a lower incidence, men have typically been more affected. The incidence of Crohn's disease among men has been increasing. It's approaching to the same or even higher than that of women. So there's no specific prevalence, determined by sex. And so how about ethnicity? Who gets Crohn's disease more often? So initially, African Americans were thought to have lower prevalence of IBD in general. However, those rates have been going up, recently, and we think those initial low numbers were due to less access to care and therefore lower rates of diagnosis. Hispanics and Asians typically have more UC or ulcerative colitis rather than Crohn's. Crohn's is a little more predominant in African Americans. In general, inflammatory bowel disease is also very prevalent amongst Jewish patients. So again, getting back to environmental factors, which is very important because these are things that you can take control of. So number one is smoking increases the risk of Crohn's disease quite significantly. For patients with Crohn's disease that have already been diagnosed, when taking medications like NSAIDs, which include Motrin, ibuprofen, that Aleve, that class of medications, that increases risk of relapse. So if you've been diagnosed with inflammatory bowel disease, you should certainly avoid both smoking as well as NSAIDs. So in terms of the anatomy, and this is where Crohn's differs from ulcerative colitis. Ulcerative colitis typically affects just the colon, but Crohn's can affect anywhere in the GI tract. So from anywhere from the mouth all the way down the GI tract to the anus. About 50% of patients do have ileocolonic. So when we say ileo, we mean the end of your small intestine where it joins the colon. So the end of the small intestine and the colon, about 50% of patients have that area affected. Some have a lot of perianal disease, about 20 to 30% of patients. And about 15 to 20% of patients have what we call fistulizing disease, which is one of the types of Crohn's, which we'll discuss a little more in detail. So phenotypes, which are basically types of Crohn's. There are three main ones. One was called penetrating, where you can have fistulas, which are abnormal connections, so essentially holes in your GI tract, so small intestine or large intestine, which form connections to other parts of the body, which they should not be. This can lead to abscesses or collections of fluid that gets infection, as well as generalized infection inside the abdomen. Inflammatory is the other phenotype, which typically don't have these fistulas or abnormal connections or holes throughout your GI tract. You just have inflammation within the lining of your GI tract. And then there's stricturing, which is the least common. This often goes undetected until patients present with bowel obstruction, but we'll see an example of that coming up soon. So here we see a diagram showing some penetrating Crohn. So this is on the left showing some perianal disease, which is very common with penetrating Crohn's, where patients can develop fistulas around the rectum and anus. And these can lead to a lot of abscess formations, which need treating and draining. And the main treatment for this are what we call Ceton or Ceton drains, where they put some little tubing through that fistulous tract, or this abnormal connection with the GI tract in the outside. And that helps to keep things draining and not developing a fluid collection, which leads to a lot of abdominal pain, fever, and worsening infection. Here on the right, we can see an example of what a fistula looks like on colonoscopy. So essentially it looks like a little hole. On the other side of that hole will be a tract similar to what we see here, and that's going to lead to a different part of the body. Sometimes it goes to other organs. It can go to the bladder, the uterus. It can go to other parts of the intestine. So fistulas are definitely something that need treating, sometimes surgically. Here we see an example of endoscopic treatment where a clip is placed to close the fistula. So stricturing Crohn. So what is a stricture? A stricture is essentially a narrowing. And the inflammation in stricturing Crohn's is what causes this narrowing. So we can see here on the left, this is an example of stricturing Crohn's where the bowel is normally about this diameter. We can see there's some narrowing, particularly in this area. You can see there's some redness here, which represents an example of some of the inflammation. This often, like I said, goes undetected until these narrowings get so severe that patients develop obstruction and they're no longer able to either pass their bowels or eat. They may present with nausea and vomiting. This on the right side here is an example of what we call an upper GI series. And we can see the contrast is going through the GI tract pretty normally, but there are some areas here that are very, very narrow, which represent these strictures. And then the third phenotype, which is inflammatory Crohn's. So this is an example of what it looks like within the lining of the colon. You can see a lot of redness, and you can have these granular presentation, which is very typical for Crohn's. So how does the disease progress? Crohn's typically has bouts of flare-ups where you have the symptoms of abdominal pain, diarrhea, blood in the stool. And in between, you have remission where you're feeling relatively normal. The goal is always to keep patients in remission, which requires medications. But without treatment, those that cycle of recurrent flare-ups and remissions is ongoing. Typically, ileal disease or the small intestinal disease, when the colon is not so much affected, can remain latent, which just means it can remain under the radar for several years. So we mentioned before extraintestinal manifestations of inflammatory bowel disease, in particular Crohn's. So these are a few examples here. This first one is called erythema nodosum, where you can have these nodules or lumps on typically present on the front of the shins, which are typically very tender, painful. They can be very red. Next is uveitis, which is inflammation of the eye. Iritis, which is, again, inflammation of the eye, but a different part of the anatomy of the eye. Aphthous ulcers, which are essentially just ulcers in the oral cavity, so of the tongue, within the cheeks, the roof of the mouth. Some patients, this is their first presentation, their first finding. Oftentimes in ENT or when the primary care doctors will refer patients, and this is their only symptom. They don't have any diarrhea or abdominal pain, but on endoscopy and colonoscopy, we do find evidence of Crohn's. And this is probably one of the more severe extraintestinal manifestations. It's called pyoderma gangrenosum, which essentially you can have pretty severe ulcerations of the skin, usually on the extremities. Okay, so again, for disease progression, you don't always have a correlation between symptoms and progression of the disease. So I put a star next to this because this is very important. Sometimes we see patients that have been diagnosed maybe at a younger age, in their 20s, early 20s, maybe late teens, and they haven't been on any medications for many years, and they say they feel fine, and they don't think they need to have routine colonoscopies or be on medications. Very important that you may be having a lot of inflammation and damage going on inside of your GI tract, even if you're not having any symptoms. Strictures and fistulas can also, again, be asymptomatic for many years. When they do present with symptoms, particularly strictures present with obstruction, fistulas typically present with a lot of fever or abdominal pain from severe infection. So when these present and you have symptoms, it's typically in an advanced stage and usually needs surgery. So our treatment goals are always to have patients achieve clinical remission, which means you're not having any symptoms from the disease. We want to have patients on steroid-free therapy. So we'll talk about steroids in a little while, but ideally steroids are just used for short courses. And ideally, we want patients to be off of steroids as much as possible. Again, a goal is always having less admission to the hospital, and we try to avoid surgery as much as possible, though we'll talk a little more about the rates of surgery in Crohn's patients. In terms of remission, besides clinical remission, which means not having any symptoms, there's endoscopic remission, and we'll see an example of that later, but endoscopic remission, this means on endoscopy or colonoscopy, everything looks normal on the camera. And deep remission is really the ultimate goal. And for patients with Crohn's, we want to take biopsies of the GI tract. We send them to our pathologist. They look under the microscope, and if they see no evidence of inflammation, even on a microscopic and cellular level, that's really the ultimate goal. So we mentioned surgery. About 70 to 80% of patients require surgery within 20 years of their Crohn's disease. 30% require a second surgery within about another 10 years. Now, we do have a lot of medications, including biologic therapies, which we'll talk about in a while. This may reduce the need for surgery, but this is dependent on if they're given early enough. So getting treatment and, of course, being diagnosed early is always key. So in terms of mortality, you do have a slightly increased mortality compared to general population for those with Crohn's. So the mortality ratio is about 1.5. Over the last 10 years, the rate of mortality for Crohn's has been on the decrease slightly. And this is mostly because of our new medications, including the biologics. Why do patients with Crohn's die? Two main factors. One, direct effects of the Crohn's disease. So this can include malnutrition, post-operative complications, and intestinal cancer, in particular colon cancer. So anyone with inflammatory bowel disease is at an increased risk for colon cancer, which is why it's very important to have routine colonoscopies. Indirect effects of Crohn. So as we mentioned, smoking is a very big risk factor for Crohn. So for those with Crohn's and that are smokers, of course, that increases risk for having any respiratory disease related to Crohn's and, of course, lung cancer. And so that's another aspect that leads to demise for Crohn's patients. So medical treatments, there are many different approaches. So in terms of what we call luminal manipulation, so we mentioned earlier the role of the microbiome or the bacteria within your GI tract. So we can manipulate that by giving probiotics and prebiotics, using different antibiotics to wipe out bad bacteria, and also your diet. So what you eat, of course, helps certain bacteria in your GI tract to flourish. For patients who are in acute flare, particularly before they had more of the biologic medications that we have now, keeping patients NPO, which means not eating anything and giving them what we call bowel rest, used to be kind of a staple of the approach to inflammatory bowel disease. But now we have a lot more options. We call 5-ASAs, aminosalicylates. So these are typically oral medications that reduce inflammation. Corticosteroids, as we mentioned before, those reduce inflammation and help patients that are in acute flare reduce their symptoms, but again, only used in short courses, not for long periods of time. Immunologics, which include our medications like cyclosporin, methotrexate, and thiopurines, like azathioprine. Those are typically used to reduce the body's reaction to developing antibodies against our biologic medications. So I think biologics are probably the most important for patients to understand. There are generally 3 categories, which we call anti-TNFs, anti-integrins, and anti-interleukins. So essentially what they mean is they target different aspects of the immune reaction and block it so that your immune system is not attacking your GI tract. So getting back to sites of action. Again, we mentioned diet, which helps to influence your microbiome. Again, probiotics, again, adding good bacteria to the GI tract. Antibiotics to control the bad bacteria as well as treat infections. The 5-ASAs or the aminosalicylates, which are the oral anti-inflammatory medications. They also come in topical, which include the enemas as well as suppositories. These are typically more used in ulcerative colitis rather than Crohn's. Corticosteroids, which treat the acute flare and symptoms, but are not for long-term treatment in Crohn's. Our immunologics, again, which we primarily use to reduce the body developing antibodies or essentially getting resistance to our medications, which are the biologics. So again, getting back to diet, there's a diet called elemental or elimination diet. This has been shown to have some advantage in mild disease. So again, keeping patients NPO, which means not eating anything, then transitioning to a liquid diet, and then finally a low-fat, low-fiber diet. From there, you reintroduce certain foods and figure out what your offending foods are, which varies from patient to patient. So typically, this includes cereals, dairy, citrus, vegetables, red meat, which typically seems to be pretty common offending food with patients with inflammatory bowel disease. Disease activity, which can improve with the dietary changes. If you resume your normal diet, your symptoms typically recover. Okay, so 5-ASAs, the mechanism of action. This acts directly in the lumen or inside your GI tract. There are multiple anti-inflammatory mechanisms of action here, as you can see. But the more important thing to know is this is a direct effect of taking the medication orally, and as it travels through the GI tract, it reduces inflammation. Now, there are different brands of the 5-ASA medications, and each has its advantages because they act at different sites within the GI tract. Most importantly, in terms of Crohn's, Pentasa here is what we typically use. And the reason we use Pentasa most often for Crohn's is because it is released in the small intestine or the jejunum, as well as the lower part of the small intestine, the ileum, and then acts all throughout the entire colon. So both your small intestine and your colon are going to be treated with Pentasa. The other medications typically are more effective just within the colon, which is why they're used for more so in ulcerative colitis, which is usually limited to the colon. So the efficacy of these 5-ASA medications, again, typically only used for the ileocolonic Crohn's disease, doesn't typically prevent relapse, definitely not effective for acute flares. So when patients come to the hospital, these are not the medications that are going to bring them into remission immediately. Now, all medications have some side effects. 5-ASAs, the common ones are nausea, vomiting, headaches, but the big ones to look out for are pancreatitis and an effect on your kidneys called interstitial nephritis. Those are the two big ones that we really look out for. So again, getting back to steroids, only effective for short-term use. Steroids do have a lot of side effects if used over long periods of time, which is why we want to avoid them. Steroids inhibit inflammation, but it doesn't lead to healing of the mucosa or the lining of the GI tract. This is why it's used for acute flares to help patients improve their symptoms when they're having a lot of abdominal pain or diarrhea. But not used long term because it doesn't really heal what the damage that the Crohn's disease does. Now, again, all medications have some side effects. So getting to corticosteroids, they can lead to something called Cushing syndrome, where you have a lot of weight gain. You can have osteoporosis, can lead to hypertension, diabetes, of course, because the steroids increase the sugar levels in the body. You can have ulcers in the stomach, can lead to psychosis in some patients. And you can have necrosis of the bones, particularly in the hip. Long-term, especially neuropathy, which means affecting the nerves, typically in the lower extremities, like the feet and toes. You can have myopathy, again, more so long-term treatment, which myopathy means the steroids are affecting your muscles, and very common acne side effect. Now, when we do use steroids, a medication called Budesonide or Entocort, which is one of the brand names, is one of the preferred steroid medications because it has less side effects and is a little more specific in terms of acting within the GI tract. So all of those effects on the bone and the other parts of the body is a lot less common with this budesonide. And the thiopurines is one of the immune modulator medications. So azathioprine is one of the most common ones that we use. It's the 6-mercaptopurine is really the active metabolite. So when you take the azathioprine, it's broken down in the body and it releases this 6-mercaptopurine, which is really what helps to act on the GI tract as well as the immune system. I briefly want to mention the TPMT gene mutation. So this is something that we measure on patients before starting them on medications like azathioprine. The reason is this is one of the genes that controls the metabolism or the breakdown of that azathioprine, which again develops which is broken down to the 6-mercaptopurine. Some people have very high levels of TPMT activity. Some patients have low levels of TPMT activity. So whether you have high levels or low levels, this can lead to some side effects such as bone marrow suppression, which means the bones are where you develop your different cellular lines or blood cells, and hepatotoxicity, which just means it can have an effect on the liver. Most important point, I think, for thiopurines, there's a very high risk of lymphoma, particularly T-cell lymphoma in young males that are taking thiopurines, particularly in higher doses. So definitely something to be aware of. And because of this, we typically give thiopurines in very low doses, and we typically avoid them in younger males. There's also a risk of non-melanoma skin cancer. Small percentage of patients can get pancreatitis as a side effect. Again, another small percentage of patients can have an allergic reaction to azathioprine. Okay, so getting into our biologic agents. These are really our most potent medications and have been really the biggest breakthrough, I would say, over the past few decades in terms of treating inflammatory bowel disease, particularly Crohn's. So again, 3 main categories where these medications target. We don't have to get too much detail in this slide here, but under the source category here, these are a lot of the cells involved in the immune system reaction, and they're activated by this TNF, and it leads to essentially going on to inflammation. So these anti-TNF medications are this category of biologics. So this is where it targets to prevent all of these cells involved in immune reaction from getting activated. So our anti-TNF agents, there are quite a few of them. So there's etanercept, Infliximab, or Remicade, which I'm sure many of you have heard of. There's adalimumab or Humira, which is also well known. And there's also certolizumab, which is Cimzia. Cimzia is definitely a very good option for young women who are of childbearing age, because Cimzia is not transmitted via the placenta to babies. So that's definitely a very good option for young women with inflammatory bowel disease. So Infliximab or Remicade, probably our most potent medication for Crohn's disease. It's a combination of human proteins and mouse proteins, and it's very effective for the fistulizing phenotype of Crohn's, although it's very effective for all inflammatory bowel disease. Downsides of Infliximab for Crohn's. Over a long period of time, so many years, your body does develop resistance to this medication. So it may be extremely effective in the beginning, but as time goes on, that effectiveness decreases. This is because of antibody formation to the drug, which is why we give the immunologic therapy such as azathioprine, which we recently discussed. So adverse events. Again, T-cell lymphoma comes up again. This is being shown to be more associated with the combination medication with the thiopurine, and more so in high doses. So, the risk is approximately 1 in 45,000 patients. So, not a very high risk, but something to definitely be aware of. And again, young males are the highest risk. So we typically will avoid using azathioprine in young men with Crohn's disease. Now, the reason we do use combination therapy is it's been shown to be more effective than monotherapy, or which means using Remicade or Infliximab on its own. And so the combination of these two medications are extremely effective, especially over long periods, because it prevents the resistance developing in the body. Adalimumab or Humira, the difference between this anti-TNF and Remicade is an IV infusion, so typically given every 8 weeks, which means patients have to come into our infusion center. They get an IV inserted in their veins, and typically over an hour or two, they have this medication infused into their IV. Humira or adalimumab is administered at home by patients that give it to themselves just by subcutaneous injections. So that's an advantage, in terms of convenience, and patients who are comfortable giving themselves injections, they can do that at home. Vedolizumab, also subcutaneous injection, and again, less placental transfer compared to other biologic medications. So typically the best option for young women who are of childbearing age, especially those who are interested in starting a family at some point. So now getting into our anti-integrins. So Vedolizumab, the trade name is Entyvio, is an anti-integrin medication. It just means it targets a different aspect of the immune response. This has been proven to be effective in inducing clinical remission for both Crohn's disease as well as ulcerative colitis, so it can be used in all inflammatory bowel disease. The one downside for Vedolizumab or Entyvio is that it can take up to 14 to 16 weeks to really induce remission. An advantage is that it's extremely has an extremely good side effect profile. So for patients who are very concerned about side effects, as well as our elderly patients where we want to minimize any potential side effects, Vedolizumab was one of our top options. And now we'll talk about our interleukins. So again, this has a different mechanism of actions, meaning it targets a different part of the pathway to inflammatory response of the immune system. And so ustekinumab is trade name Stelara. This one, in terms of its administration, is kind of in between. So Remicade and Entyvio are all infusions, so we come every 8 weeks approximately for new infusions. The Certolizumab and the Humira, those are subcutaneous injections you get at home, given to yourself. Stelara is kind of a hybrid where you get your first dose as an IV infusion, but going forward, you give yourself subcutaneous injections at home. So very effective medication, also has a very favorable side effect profile, very safe medication. Again, oftentimes used in elderly patients or those who are very worried about having side effects. So when we are treating patients, how do we assess how well we're doing and how well we're controlling disease? So again, there are kind of different types of remission. Clinical remission, so meaning patients feel well, they're not having abdominal pain, diarrhea, blood in the stool. Those are the 3 big ones we look for. There's serologic remission, so blood tests such as ESR and CRP, which are measures of inflammation in the body, are normal. Endoscopic remission, which means when we do endoscopy or colonoscopy, the lining of the GI tract or your mucosa looks normal. We don't see any ulcers, we don't see any redness, everything looks healthy and normal. Then deep remission or histological remission is when we take biopsies during endoscopy and colonoscopy, and even on a microscopic level, there's no evidence of inflammation, which is really the ultimate goal. So mucosal healing, what do we mean when we say mucosal healing? On the left here, we can see a picture of a colonoscopy in a patient with Crohn's disease. You can see the Lining of the colon is very kind of lumpy, bumpy, and we call granular or cobblestoning, which is classic for Crohn's. You can see it's bleeding here, which means the mucosa is very sensitive or friable. So this is why patients typically have diarrhea as well as blood in the stool. On the right here, this is a picture of a normal colon. So we can see healthy pink mucosa or lining of the colon. You can see the blood vessels very clearly that are supplying good blood flow throughout the colon. So this is ideally what we want to see in all our patients. So oftentimes we get patients referred to us that have positive antibody testing. So ASCA or anti-Saccharomyces cerevisiae antibody, as well as P-ANCA. So these are two antibodies that typically can be abnormal or elevated in inflammatory bowel disease, but they are not definitive. So they're not something that we typically will get on most of our patients. However, there are some rare scenarios where it can be helpful in distinguishing ulcerative colitis from Crohn's, or when the diagnosis is not quite clear, I'm not sure whether or not this is inflammatory bowel disease or something else is going on. Now, C-reactive protein, this is one of our blood tests that we do. We're very sensitive for inflammation in the body. It's found in blood. It's made by the liver, and the liver makes a large amount of this protein when you have a lot of inflammation going on. This correlates pretty well to a disease activity in inflammatory bowel disease. So if you have a lot of inflammation going on in your colon or small intestine with Crohn's, we expect the CRP to be typically elevated. Fecal Calprotectin is another non-invasive marker of inflammation, so it's a stool test. This one is more sensitive for intestinal inflammation. So CRP is just a blood test of overall inflammation in the body, but that can be elevated in any kind of infection. If you have knee or joint inflammatory disease, that will still be elevated. Fecal calprotectin, more specific to intestinal inflammation, which is what we really want to look for in Crohn's. This also correlates pretty well with disease activity. The reason CRP and calprotectin are important is we can't do colonoscopies all the time for all our patients when every month or 2-3 months that we see them. So we need to have other markers that give us a good idea of how well controlled their disease is, and these are two of the best markers. So in summary, Crohn's is a chronic disease. It's a lifelong disorder, something that you have to continuously manage, not something that you can take medications for and cure. Even if you're feeling well, you can still have a lot of inflammation going on in the colon. So very important to take medications and stick with it long term. Your risk for colon cancer with inflammatory bowel disease and Crohn's in particular is increased for colon cancer. So for this reason, we do colonoscopies on all our Crohn's patients annually. When the disease is very well controlled, we typically will extend that to every 2 years. If uncontrolled, your Crohn's can lead to multiple hospitalizations when you have flares of your symptoms. It can lead to surgeries, but we do have effective treatment that can avoid some of these complications or at least minimize them. That's why close follow-up with the gastroenterologist is essential, so you can have good control of your disease and follow the appropriate treatment, which may need to be changed from time to time, and also keep up with your colonoscopies, typically once a year, to detect any early changes and prevent the development of colon cancer. And a take-home point, while Crohn's is definitely a challenging lifelong condition, we have very effective treatments, and it's not something that you have to suffer with. So see a gastroenterologist, You can get, medications will help you get into clinical remission, meaning you'll feel healthy and normal, and you can lead a very healthy, happy, normal life having this disease well controlled. So the most important thing is make sure you are controlling disease and don't let it happen the other way around. Don't let the disease control you. And here are some of my references, and I think we have time for some questions.
Hi, thank you, Dr. Pinto. That was awesome. We do have some questions that came in. So question number one is, since you can't eat high fiber foods and your diet is limited with fruits and vegetables, how do you get the proper amount of essential vitamins and minerals?
Okay, so very, very good question. So, I think you're referring to the elemental or elimination diet. So this is something not long-term. It's something that, one approach to treating flares of, acute flares of your Crohn's or inflammatory bowel disease. So when your GI tract is very inflamed, allowing it to rest and heal is really the goal. So eating nothing and then transitioning to this liquid diet, and then leaving out these high fiber foods, which are typically healthy foods to eat. But at the time of inflammation, those foods have been shown to typically cause a lot of irritation in the GI tract. So I don't want to give the impression that you should avoid fruits and vegetables on a long-term basis. This was just one of the the approaches for treating very mild flares of disease. And this is, I would say, something that was done more so before we had other medications, which we now have that have been developed more recently that are very effective. So not a very common approach. Definitely something seen a little more in pediatric GI rather than adults.
So interestingly enough, the person just wrote back and said her son's been told to avoid most fruits and vegetables all the time.
Right. So again, much more common for pediatric GI, and that's typically because younger patients are not started on these biologics as frequently or as soon as the adults. So the goal of the elimination diet and the elemental diet, that is helps to kind of tease out what foods cause your flares of your disease, which again varies very much from patient to patient. So some patients can eat fruits and vegetables and have no issues whatsoever. Some can eat red meat and no issues. So it's kind of there's no real diet that is recommended to follow for Crohn's or inflammatory bowel disease, which is a reasonable question, one that we get often. But unfortunately, we can't give any specifics because it varies from patient to patient. So the most important thing is monitoring how you react to certain foods, and avoiding those going forward.
Thank you. Can genetics play a role in developing Crohn's?
100%. I would say genetics probably the main factor. One of my earlier slides tried to make that bubble the biggest because patients with parents who have inflammatory bowel disease or first-degree relatives, again, extremely high correlation. I believe 90% or higher for identical twins. So genetics is probably the number one, risk factor. Although, as we can see, the environmental factors are also very important.
Great. What about stress? Can that cause a flare-up of Crohn's?
So stress, clinically speaking, stress has definitely been affiliated with flares of Crohn's symptoms. A lot of studies have been done in terms of measuring inflammatory markers or doing colonoscopies with biopsies during times of stress when patients feel like they're more stressed out. there hasn't been a clear correlation in terms of the objective markers, but there's definitely been a correlation in terms of the way patients feel, and they feel like certain stressors, life stressors do lead to more symptoms. So stress is definitely on the list of environmental factors.
And then what about alcohol? Is that something that a person with Crohn's can have?
So, I would say on the anti-inflammatory, antioxidant side, some have, I guess, posited that red wine may be an advantage to leading to reduced inflammation. But typically, we definitely recommend avoiding alcohol. Does cause, even in normal patients without inflammatory bowel disease, inflammation does happen, particularly in the upper GI tract when ingesting alcohol. So again, one of the things that you have to gauge your reaction to when you, just like eating particular foods. But overall, I think I would recommend avoiding alcohol. Definitely in large amounts.
Thank you. Do you have any reputable website recommendations on how to live well with Crohn's?
Sorry, how to
live well with Crohn's.
Live well with Crohn's. So, I would say the GI, the American College of Gastroenterology, ACG, I believe it's acg.org. They have a lot of patient information there. I think that's definitely a great resource. Essentially, one of the most reputable sources. So I would check out their website. They have a lot of patient information there.
Excellent. And I think this is the last question I have here. If you're feeling symptoms, at what point should you go see the doctor?
Right. So good question. The symptoms that typically happen with Crohn's or inflammatory bowel disease, abdominal pain. Everyone has some stomach aches sometimes. Diarrhea. We all have diarrhea once in a while, and it depends on if you eat something that maybe was not so good. I think the key is how frequently these symptoms occur and how persistent they are. So if you eat something bad, you have food poisoning, we expect 24 to 72 hours, that should go away. And it shouldn't be happening once a month or every month. That should be a once in a blue moon type of symptom. But if you're having abdominal pain or diarrhea that's persistent, or if you have blood in the stool, I think you should never have blood in the stool. That's always abnormal. So blood in the stool warrants immediate, visit to your gastroenterologist. But persistent symptoms in terms of abdominal pain and diarrhea that are not going away or getting worse, then that's when you should come in to get checked out. Again, it's not that this will always be inflammatory bowel disease. It can be irritable bowel syndrome, which has very similar presentation. But the key is that any of these conditions we are equipped to treat, and we don't have to suffer through these symptoms.
Great. Thank you so much. I think that's the last of the questions for this evening. So thank you so much, Dr. Pinto, for your informative presentation this evening.